Well, I think what we're seeing is in many countries, in Europe, in North America and in Australia, a great deal of reform momentum around the transition to adulthood, from childhood, puberty, through to the mid-20s. And we're seeing an understanding that it's a much longer period of transition than in the past. And it's also the period in which all the adult-type mental disorders emerge and really become a major problem during this transitional period. One of the problems is that even though 75% of these illnesses appear before the age of 25, with a big surge during adolescence and early adulthood, very few of these patients get access to treatment, certainly timely treatment. If they do get access, it's after long delays, and it hasn't been a good experience for them because the sort of services they try to get access to are not really designed for them. So these are the motivations why people are starting to reform, the structure of services, primary care and specialist care, so that they're more youth-friendly and more effective in helping young people. Well, there is this idea that even though young people have very high levels of mental ill health and distress and problems, that somehow it's just teenage angst. They're just going to grow out of it. It's going to be okay. But if you look at the facts, 50% of these young people will meet the criteria for a diagnostic threshold of some sort. And if we look at how much mental ill health they experience during the transition, it predicts very strongly how they're doing in life at age 30. So if you've had a certain amount of mental ill health during the transition, then you're more likely to have fewer friends, you won't have completed your education, you'll be earning less money if indeed you've got a job, and you might be dead. You might have died from suicide, or you might be on disability support, you might be homeless. So the neglect of treatment of these young people does have real consequences, and we're a long way away from, I suppose, over responding to teenage angst and mislabeling it. If the treatment system, if all it's able to provide is a prescription, then that's completely inadequate and does pose risks. But what we have to set up is a stepwise or stage-based treatment system or care system that allows people to just get simple interventions first, just education and support, psychological help, social interventions. And if these are insufficient, then you might consider medication and other more complex treatment, more complex psychotherapies too, but in a stepwise way. So you're responding proportionally and not over-treating. But the big danger at the moment is under-treatment, under-response, because the majority of young people don't get any help at all. No one's there fighting with them or working with them. The division of psychiatry is very much based on a pediatric adult sort of model, which sort of works reasonably well, you could say, for physical illnesses, because there's a kind of during adolescence and early adulthood, there's relatively little physical illness. It's mostly mental illness and mental ill health. But it doesn't work for psychiatry because of what I just said, that the main health issue across this boundary between childhood and adulthood is mental illness. So I think we probably need to think about who's going to look after these young people in transition. Is it going to be a sort of extension downwards of adult psychiatry or an extension upwards of child psychiatry? Child psychiatry is well positioned because it already does try to include adolescents. But it doesn't go far enough. The other choice would be to define a new zone called youth psychiatry. We did that probably some decades ago with old age psychiatry. Prior to that didn't exist. It was just lumped in with adult psychiatry. But we defined a different age-related zone for old age psychiatry. We could do that for young people, and there'd be a very strong justification for doing that. But there's an opportunity for child psychiatry to sort of embrace it and say, no, we'll take responsibility here. We'll extend our thinking and our mandate to include the full transition to adult life. And but that requires a lot more resources. It requires much greater knowledge and expertise about this transition to adulthood than child psychiatry currently has. There's a lot of new things we need to learn, and that's something for the leadership of child and adolescent psychiatry to think about very seriously.